and access for individuals with IDD and mental health needs. The presenters will be Ashley McReynolds with the Arc of Louisiana and Dr. Brandy Kelly with the Office of Citizens with Developmental Disabilities. You can read the description for this session and their bios on page 20, 21, and 22 of the conference booklet, which will be linked in the chat below. And with that, Dr. Kelly and Ashley, I'll turn it over to you.
Thanks, Liam. Good morning, everybody. My name is Ashley McReynolds. I am a program director at the Arc of Louisiana. I am also the parent to a 17-year-old that has an intellectual disability and pretty significant co-occurring behavioral health conditions. I am a white female with shoulder-length brown hair, wearing a pink top, and I also have pinkish purple framed glasses. And now I'm going to turn it over to Dr. Brandy Kelly with the Office for Citizens with Developmental Disabilities.
Good morning. I'm glad to be with y'all this morning. I am Brandy Kelly. As both Liam and Ashley shared, I work for the Office for Citizens with Developmental Disabilities. I'm the clinical director for the office. I also have a sister who has an IDD disability and receives services, so I am a family member as well. I am a white female. I have chin-length curly hair, brown hair. I'm wearing a white shirt and brown glasses, and I'm happy to be here to spend this time with you today.
Okay, just to get started, I just want to cover a couple of the objectives that we hope this training will help sort of better help you align and be able to identify what are the key systems in the state that you're going to either receive services from or need to receive services from, and the stakeholders that are involved throughout the state of Louisiana, both in the systems and then out in the community as well. We hope that you will, at the end of this, be able to identify 2 strategies for change. Could be within current services or the addition of new services that will help better meet the needs of individuals with intellectual developmental disabilities and co-occurring behavioral health conditions. We also hope that by the end of this, that you will be able to identify 2 additional strategies for better cross-systems collaboration, so that those key systems that we're going to talk about, how they can collaborate better, and some opportunities for some trainings.
Right, so I'm going to share some just background information of just a lot of things that have changed in many of the systems that individuals with disabilities and their families need to access. That kind of led to some of what Ashley and I are going to share with you today, and some of the work and the changes that hopefully we will take moving forward. So in the developmental disability system, over time, prior to the pandemic, we certainly saw a lot more people being served in home and community-based services. We closed a number of state-operated programs, and some of these programs included some specialized services, for example, for youth with legal involvement, and adults that had some sexually related challenges. We also downsized and privatized, or had private providers agree to run 3 other state programs that we had. And this included a stabilization unit that we had for people with IDD and mental health needs, but the private provider was not able to continue operating that part of the program. So that was another program that we lost in some of those years. And then we also lost some state employed clinical staff that were helping to address some behavioral health and psychiatric concerns. At the same time, in our Medicaid and behavioral health systems, there was a move to managed care. This was a little bit different for behavioral health services versus physical health services. So we, as a state, we implemented managed care for all Medicaid services, but individuals who received services through our DD waivers or who were on the DD services registry could opt in or out for those services. So they didn't have to be in managed care for their physical health or their early periodic screening and diagnosis and treatment services. Those are the services that youth have to be able to access through Medicaid, and the state has to provide. But if you received our DD home and community-based waiver, or you were on our registry, you could choose to stay in what they call fee-for-service or legacy Medicaid for those. But you could also opt to do it through a managed care entity. Behavioral health services were then moved into managed care. But the difference is that for behavioral health services, you cannot opt out of managed care. That's the only place that you can get them. There was also implementation of a coordinated system of care for youth that crossed various systems. And at the origination of this, when this started, youth who had our waivers in the OCDD could not access some of those services. And then that has now recently changed in 2017. So you can see there have been continued changes. And there were also some closure and privatization of some of the behavioral health programs, including what people probably have heard of before as the DNP unit, or the developmental neuropsychiatric program, which was at the old Southeast Hospital and was a program for adolescents with IBD and behavioral health needs. So a lot of changes happened in the decade or so before the pandemic. And these sort of set the stage for both some positive changes, but also some unintended negative changes. And so the intent of these services was to have more privately operated services and a little bit less reliance on state operated services, and to have more people getting services in their home and community, and fewer people getting services in some sort of an institutional setting. And that stated goal, those two stated goals happened with these changes, right? So we do have more agencies that are not the state that are operating in programs and offering services. And we do have more people getting services in the community than we did before. The challenge is that we had some unintended consequences in this work. And some of that was because perhaps all the right people were not necessarily involved in and engaged with how we made those changes as a state. And so those consequences were not necessarily known. And so that led to the office working closely with the Arc of Louisiana and other stakeholders to make sure that we really stopped for a minute and took a look at what do we need to do differently, right? So we brought in a lot more stakeholders. So we worked with individuals and families who receive services. We worked with advocacy agencies. We worked with the districts and authorities, or what we call our local governing entities. On this slide here, it is what we're referring to when we say LGEs. We worked with provider agencies, people who were actually out there trying to help people meet their day-to-day needs. And we also worked with other state partners, right? So there were other service systems, not just the DD service system. And so we needed to be talking to our colleagues in the Office of Behavioral Health and Medicaid, our colleagues in the Department of Child and Family Services, the Department of Education, et cetera. So we really reached out to ask people, what is working and what is not working. And so we did that through some collaborative work sessions and feedback sessions. And we looked at how does that help us to look forward to, better work together and collaboratively develop goals. And then how do we make sure that moving forward, we have ongoing stakeholder group and feedback sessions. So this really helped us to see, while some things maybe happened with the changes that were what people wanted to happen, there were also some things that we didn't anticipate that now were new problems and new issues that we were going to need to work through. Actually, I don't know, this is the slide you and I talked about. You may have some comments on too. So before I go to the next slide, I don't know if there's anything you want to add or share here.
Not particularly. I do just want to say that I wanted to make sure that from my experience with, having to work with the systems, trying to locate services, crisis type services, I found that the Office for Citizens with Developmental Disabilities, or OCDD, had a better understanding of how all of the systems worked and how families could go about navigating them. Where I struggled was with the Office of Behavioral Health, not quite understanding or not being as familiar with the OCDD system. And the breakdown then became even further with the involvement of the managed care organization. And as a family member that lived in crisis for a long time, I felt it super important that I get as many families in similar situations as myself to come to the table, be willing to share, because their personal experience, their lived experience, to me was the most important piece that could drive the change that was needed to help better serve their loved ones and just better improve their entire family unit as a whole.
So to kind of add to what Ashley just shared from a family experience, one of the things we did as an office in working with Ashley and other families and looking at sort of what was working and what wasn't, is we looked at many of the things we had tried to do through our office, in particular, utilizing our resource center staff, which some of you may know and some of you may not, or some clinical staff. So we have psychologists, social workers, speech therapists, physical therapists, occupational therapists, who worked for us previously in some of our programs that we were able to keep, that we have now built into a statewide resource center. And a lot of times, folks ask for our resource center staff to get involved, and there's a lot of reliance on us. And what we were discovering was that while the resource center does do a lot of good work and have a lot of good outcomes, we can only directly touch and interact with so many people. And so what we wanted to do was figure out, how do we take the good work we have, but actually extend the outcomes? Because despite some of this good work, what was apparent was we needed to be engaging more with all of these other systems, while also working with families, because the OCDD service system just doesn't have all of the services that are going to meet everyone's needs. And so these are just some things that we continue to do most of this in the resource center, but you'll see as we go through the presentation how we're using this to sort of build on our own systems, but also how we can interface with other systems and work better to get better outcomes. So we have what we call an urgent triage and diversion process. And this is where if someone is living at home in the community and they may be at risk of losing their current living situation, we have a partnership between the district and authority and our resource center staff to engage and outreach to that individual and their family and any support system they have if they're receiving services, to look at what could we do to help them be able to sort of stabilize their current situation and continue to live, work, and receive services if they are in their home and community. And what we know is when we're able to do that early, when our resource center staff is able to partner with the local office, 90% of the time we can divert any movement to a more institutional setting or a more sort of intrusive set of services for that person. And we also know that 99% of the people we get referred through this process have co-occurring behavioral health needs. So this is not something that is happening frequently for individuals who have a disability condition and they don't also have co-occurring behavioral health needs. We also have a partnership with the districts and authorities to look at individuals who have had a history of some non-consensual sexual behavior. We know that there are times that folks may struggle. They may or may not understand some of the actions. They may also have a history of some trauma. And we want to be sure that these are individuals who are getting the supports, education, and supervision they need so that they can continue to also live in the community and not have a recurrence of those types of behaviors, which put them and others in the community at risk. We currently follow through this process over 200 individuals statewide. 100% of those people that we follow have been able to maintain their ability to live and work in the community. And we have a very, very low recurrence rate. And usually it is not a recurrence that actually has direct contact with another person. So this has been a really effective process. So we know through these first two processes that when we can partner early with the local district and authority and bring in additional resources, we can effectively support people even when they have co-occurring behavioral health issues or behavioral concerns that might place them or others at risk. The Resource Center also does direct treatment in instances where there are no other services, or we will consult to a clinician who maybe hasn't had a lot of experience providing behavioral health or medical treatment to an individual with a disability, so they can modify treatment and be effective in terms of having positive outcomes. 95% of the folks we engage with are able to continue to live and work and receive services in the community. And we also have a 98% satisfaction rate. So again, we know that effective treatment can be provided and can be successful. We've also done some technical assistance projects with providers and with clinical agencies. So the DDC is, of course, the DD Council, and the TTI is a SAMHSA Transformational Initiative grant. And in the work that we did with these providers, we were able to decrease emergency room visits, hospital stays, critical incidents. And we also saw positive outcomes in terms of increased connection and relationships and steps towards community employment. And then we do professional training and continuing education to clinicians, and we also get a pretty high satisfaction rating on our evaluations and a lot of requests for more. So I share this not just to say our Resource Center staff are doing great work, although they do, but to tell all of you that even with these good outcomes, the challenges that Ashley shared as a family member were still happening. And so when we looked at what was working in the system and what wasn't, and we also looked at, even with the positive outcomes we were getting from our work, we couldn't meet all of the needs. So we really felt like we needed to do some things differently. I think Ashley's going to share what the families felt needed to be the first step and got us moving in the right direction in a moment. But we wanted to look at, okay, so how do we expand this? How do we go beyond just what our set of clinicians can help people with behavioral health and disability conditions do in terms of positive outcomes? How do we spread this? How do we get better outcomes for more people and make sure that the family experience isn't the way that Ashley described, and that everyone doesn't have to wait until they can get to one of our clinicians to actually get the services that they need? So I'm going to turn it over to Ashley to talk about what the families sort of pulled together and working with the Arc and other agencies to begin to sort of spearhead how we could move forward.
So a couple of years ago, I personally experienced some pretty significant crisis situations and was unable to access any type of community-based type services. We were landing ourselves in the emergency room, unable to find any type of assistance through private residential treatment facilities or PRTFs. Hospitals were not wanting to accept my son due to their inability to accommodate was the reasons that we were getting. And we were just left sort of turn after turn being denied assistance and help when we really needed it the most. So unfortunately, I was not the only family member. As I reached out to family members, to friends who are also sort of trying to navigate these systems, I was hearing the same story like mine over and over and over again. So we began talking about what can we do to try to, again, pull a group of people together to really take a dive into both systems, to all of the systems that, unless they work together, our loved ones are not going to get the care, the support, and the services that they need to be successful, to remain living in the community, all of the things that we all want for our loved ones. To be honest, when I first looked at this, the first thing that came to mind was we need to bring back the developmental neuropsychiatric unit, the stabilization unit. Those were the two main services that were once available that I really fought for and that I thought were needed to bring back. Families are experiencing issues in accessing providers. Most don't accept Medicaid. If they do, the wait lists are extremely long. Access to applied behavioral analysis, or ABA, is very difficult. There are wait lists. The older your child gets, the less clinics that are available to serve them, because most do not serve an older population. So the services that are available were very limited. And it just became difficult, and families just continually expressed that they were unable to locate the needed services for their loved one. So this is why, I brought together this group of people. We started talking about, let's put together a formal work group. And that was sort of how this stakeholder group came about. And we wrote, which is now HCR 33, and really put together, I think, a really great HCR with some very specific goals that we'll talk about in the next couple of slides. Next slide, Brandy. So the saying is true: if you build it, they will come. But as I worked through HCR 38 and we had, just larger discussions with the right stakeholders at the table, it was very clear that a place or a particular unit really wasn't the solution after all. There are community-based services. We have a need for significant changes and additions to crisis services that we hope we can further build upon, that will shift the need away from a place for these individuals to go and receive specialized type services. I realized that if we do build these fragmented or segmented places or units within the system, that at the end of the day, we're just going to further fragment the system that provides the services that our individuals and loved one needs. So we really tried to shape the focus around the larger community style services, looking at ways that we can work together to provide educational and training opportunities for current providers to be able to feel more comfortable, be better equipped to serve individuals that have any type of intellectual or developmental disability, to build the number of providers across our state that are, again, comfortable and willing to serve this unique population. So as I said, while the conversation started with the need for a specialized place for individuals to go and receive services, it very much then shifted. And it was due to family experiences, to the feedback of individuals themselves who are experiencing these difficulties, that really began to shape the discussion, which led to really just a better outcome and a game plan across all of the systems that truly have to work together to serve this population. Brandy, I don't know if there's anything you'd like to add. Okay.
Sorry,
so,
I muted myself, Ashley, and then didn't unmute myself. I think.
Oh, gotcha.
I think you covered all that very well. So I'm good to go to the next slide.
Okay. So HCR 38 was written in the 2022 legislative session. And within that HCR, we spelled out very specific recommendations, things that had to be studied across all of the key systems that provide services to this population. So we needed to have everybody look at everything and then come back to the department and provide very specific recommendations on certain categories. So some of those categories were increasing access to existing community-based services, some type of interface with a new crisis system, and that there was access to those services when families or individuals needed them. So it took us looking at what does our systems currently offer versus what are families truly looking for in terms when they encounter like a crisis situation. So we looked at all of that. We have to engage our managed care organizations because, like Brandy noted earlier in this presentation, managed care is now the way that we all receive our behavioral health services. And I, as a family member too, have encountered many issues when trying to reach out to my managed care organization when looking for behavioral health services. And when I would let them know that my son also received services through OCDD, a lot of times I was just sort of transferred back to OCDD because all they saw and all they heard was that he had a developmental disability. And so this was a part, and he needed to go and be served by OCDD. Well, what I really needed was some comprehensive behavioral health services. So I thought it was super critical that we engage the MCOs in this HCR process. They were a part of our conversations. They heard from myself, from individuals and other family members about some of the barriers that they were facing when they were reaching out to their managed care organizations and what families truly needed when we did make that call. We also discussed and talked about the need to really implement some specialized education and training when looking at future doctors. This, unfortunately, what I've learned over the past couple of years is that for a long time, I felt like my son needed a behavioral health professional that was specialized in treating individuals also that have like an intellectual development disability. And sometimes that can be true. But what I also learned is that there are hundreds and hundreds of fairly simple accommodations and modifications that psychologists, psychiatrists, social workers can make to, the assessments, to how they provide, like their services in office. They can make their current behavioral health services accessible to people that have intellectual and developmental disabilities. So while there's still a significant need for training, there's also a significant need for just an increase in these types of clinicians. There's a significant shortage in Louisiana. This is also a nationwide issue. So Louisiana is not any different than most other states in having a lack of access to providers. But we also need to train current providers and those coming up through the system in their residency or early years of practice about certain accommodations and simple sort of modifications that can be made to better serve individuals that have intellectual and developmental disabilities. Also, the need and the recognizing that there are just certain situations where individuals need some type of, placement or treatment to have access to residential options when they're needed. And what we have found that there are very few of those PRTFs that are truly equipped to accommodate individuals with intellectual and developmental disabilities. Brandy noted in a couple of slides back that there was a grant a few years ago with the Developmental Disabilities Council that really led to some great partnerships with some of these providers. And it has made a difference in the types of treatment and services that these individuals has received at these particular facilities has led to, their name just getting out and individuals looking to go to those specific providers. So just the need for that continuing education within the providers is also still important and still needed. So we got a group of, there was about, I think 20 or 22 of us total. It was spearheaded by parents and advocacy groups. We did lead sort of the conversations. We got a ton of support. We didn't have any opposition on this particular piece of legislation. It was supported across party lines. It was co-sponsored across party lines, which was great. And it really forced some difficult but needed discussions across these key systems that we look to in times of crisis, and then just in our everyday look to get the needed supports and services that our children, our adult children need to be successful. So here's an overview of the stakeholders that were specifically spelled out in the HCR, which I also think is important to note that I went through and named not just the systems or the organizations, but who specifically from those organizations needed to be at the table. So you'll see here, we have OCDD, the Office of Behavioral Health, our managed care organizations, our coordinated system of care or CSOC, a lot of parents. We had providers of developmental disability services. We had behavioral health providers that included one private residential treatment facility provider. We had clinicians across the board. Some that have moved into the private field, but were part of the resource center. So I really tried to ensure that I included all of the key players in the systems, and then brought together a range of individuals with disabilities that also had co-occurring behavioral health conditions, and then parents across a wide range of ages to ensure that we had those that were, younger, or middle-aged youth, and then up to adults to try and get the best possible outcome. And we all put together, a lot of work. We came up with some really great recommendations that all of us supported, which I also think was super important. So when the department received the report with those recommendations in them, that every single person a part of this group agreed that these were what was needed and sort of spelled out to the department, these are some ways that we think we can start to initiate these conversations to get these needed services that we either need to expand upon within the systems that we currently have, or look at bringing new services on board that we haven't had in the past.
All right, so we are going to spend some time on the next few slides actually sharing with you a little bit more detail about the recommendations. And once I share that with you, Ashley and I will kind of each take turns sharing with you where we are already seeing some progress related to these recommendations. I want to add, just to echo the importance of bringing together all of the people that were brought together and the agreement that Ashley mentioned. So I led the group and wrote the report, which then had to go to the department leadership to review. And while we had some minor edits that they requested, I think because the right group of people were brought together and because we were able to think through these recommendations in a way that was really designed to maximize access to what already existed and to really think through how we could look at anything new, we had total support from department leadership that they felt confident that we could move forward with these recommendations. There was no concerns or questions about any of the recommendations, and all of the recommendations stand in the final report exactly the way that the group made them. I want to highlight that you heard Ashley share that sort of in that desperation that she felt as a family member, and in talking with many other family members who were at that same place, they really were at the beginning thinking that there are times when our children are experiencing some intensive behavioral health needs and they need a place to receive treatment. And sometimes that treatment can't happen in the home. It just doesn't feel safe. And so there was a big focus on the sort of residential piece and the sort of a specialized unit. And I just want to call your attention to the fact that the vast majority of the recommendations that we made, you will see, were actually in accessing the services that were in the community. So we, as a group, made 15 recommendations related to accessing community-based services and or expanding them. We have 6 recommendations to work better with our managed care partners, 4 recommendations related to crisis service access. So all of those are actually in the community arena, right? And then we had a small number of recommendations. So we have 4 recommendations we'll cover that were related to how do we make sure people can access psychiatric residential treatment facilities when they need them. And then we had some recommendations related to considering specialty units, but you'll notice we had more guidance that was put out by the group that if we were going to pursue as a state any form of specialized treatment, how do we do that in a way that actually makes sure that we don't assume that simply because someone has a disability, they have to access a specialized service, because people should be able to access the same services that any of us could access. And that we also make sure that we don't create sort of separate fragmented systems that might be more costly and less sustainable over time. And then we had some additional recommendations that sort of fell in the other category. And most of those had to do with community-based services too. So I'm going to share these various recommendations with you. We'll go through each of the groupings. So in terms of increasing community access, one of the things that I think was really interesting in the group was when you actually look at the type of services that are available that Louisiana will pay for and that the managed care entities can authorize, we actually have a pretty good array of services for behavioral health needs. That doesn't negate some of the things that Ashley shared, but what we figured out was the problem isn't that we don't have services. The problem was other things. So one of them was education. So I know, Ashley, you said this in the group. I think a couple of our other families, I didn't know we had all this in the behavioral health system. So I think one of the things that we discovered was that when a family member is trying to access services for someone with a disability, you get really familiar early on with the OCDD service system, and also probably what you can access and expect from your school related to your child's disability needs. But there's not necessarily the same awareness and education as it relates to what can you access for your child's behavioral health needs. We also, though, got some feedback from some of our partners, particularly our partners in the coordinated system of care, that they were also seeing the opposite happen, that family members who had young children who early on really had some very clear behavioral health needs, but might have some disability needs as well. When the behavioral health need was really at the forefront, they often knew more about how to access behavioral health services, but people were missing that the child might also have some disability needs. And while all this work wasn't limited to children, one of the reasons this focus was on talking about families and young children is because we all know that the longer we have to wait to get people access to what they need, whether it is for their disability needs or whether it is for their behavioral health condition, we lose valuable time that can affect the outcomes that person has in their life. We also, so we really wanted to focus on education across systems. And that was for parents, but it is also, and you'll see a repeat of some of this when we talk about how we can better partner with our managed care partners, is also making sure each system understands the other systems and that we all know what everyone else does and does not do, and how do we work together? How do we access and help others access it? There were recommendations about how our districts and authorities can be used to help in this effort, because the districts and authorities have a behavioral health division and a developmental disabilities division. So there are some recommendations about how the department can work with our local districts and authorities to look at how they can do some creative things to serve individuals who may have needs across DD and behavioral health, because they have the ability to work sort of across their offices and divisions. And they also provide some behavioral health services. So when people have trouble accessing those things, that could potentially be a resource. We made some recommendations in conjunction with the managed care partners who were a part of this, that they would look at possible billing and coding options. And most of us don't want to have to worry about how somebody bills and codes, and we shouldn't, but we all know that if somebody can't get paid to provide a service, it becomes an access issue. And we do know is that some of the modifications that Ashley mentioned sometimes then mean that maybe treatment's going to take a little longer, or it's going to a session might last longer, or it might have to be different. So the managed care entities worked really well with us, and they are going to be looking at, are there some ways they can make sure that when someone needs a therapy or treatment of some sort, that the clinicians who need to provide this are able to actually bill and authorize for what is needed, and that we can make sure that that is not a barrier. We had recommendations related to improving collaboration across entities. As a family, it can be very exhausting to have to continually repeat your story, right? To have to tell the story over and over from the beginning. Sometimes it's frustrating. We have services that are all within the department, but maybe they're overseen by different offices, and yet it's not neat and efficient how we talk to one another. So how do we have all of the coordinators in all these different systems know about one another, know how to talk to one another, and plan together, so that planning isn't happening repetitively or in different sort of fragmented ways. There is a new community health worker option that the department is supposed to be looking at implementing. And so one of our recommendations was also assuring that this option was accessible to individuals with disabilities and their families, and that as this option is implemented and rolled out across the state, that families are included so we can make sure that it is available and accessible, and that they know also the disability services and how to help people navigate getting what they need. We made recommendations as a group for stronger partnerships with universities and licensing boards, so that we can begin to have dialogue about how do we make sure that every clinician training program includes information on understanding the needs of people with disabilities, and how to make sure that whatever practice you are going to school to learn as a clinician, that you know how to make sure that people with disabilities can come to your clinic, your practice, et cetera, and that you can feel comfortable providing services and knowing how you might need to modify your office, the way that you do sessions, et cetera. And the reason we have the licensing boards there is because we also want to be sure that we are getting to clinicians that are already providing services, right? And getting continuing education out to them. And our stakeholders in Louisiana have had real success in getting some requirements for dental education out there. And so we want to do some similar things with other disciplines in the behavioral health arena, so that people need to get continuing education to be able to really better serve individuals with disabilities. There are recommendations that are encouraging the department to assure continued funding and resourcing of their OCDD Resource Center, because that is where we have our largest hub of expertise. And the Resource Center is able to sort of collaborate and consult on many of these activities and recommendations. So that is something that we wanted to make sure we did not lose. The Arc of Louisiana had also kind of around the same time, and Ashley's going to talk a little bit more about this, had just begun a grant related to meeting the needs of individuals with IDD and mental health concerns. And so the group also wanted to continue the work of that grant and actually agreed to expand to include the entire work group. There are recommendations on needed collaboration between managed care entities and private insurers, because some of the individuals who receive services through our disability system continue to have private insurance in addition to Medicaid. And we noticed that their families were able to share there were sometimes some drop-offs between those things, those funding mechanisms. We have some recommendations on looking at how we can incentivize the assertive community treatment teams to be more able to engage with and serve individuals with disabilities, because we do know that these teams will come to meet people where they are in the home and the community when they need services. And that can be of great benefit to individuals and their families. But not all of these teams have experience in providing that type of service. And it also, some of the research that we were able to look at shows that sometimes you need some additional resources because of co-occurring medical needs that individuals with disabilities might have, and some of the ADA background that Ashley mentioned. So incentivizing them so that if they need some additional consultants or resources, that they might better be able to do that. We also discovered that we have some additional therapies in our Children's Choice Waiver and a complex care add-on option in our new opportunities waiver in the OCDD system, and no one's accessing it. So we got a lot of feedback about either there weren't providers of those services, or people felt like the process was either difficult or people didn't understand it. So there were recommendations for our office to look at what are the challenges. Why are we not getting providers to enroll for some of the therapies in the Children's Choice Waiver? And what are the challenges in the complex care add-on request process for the new opportunities waiver? And then we made some recommendations for some additional services to consider in our waiver. likely starting with the new opportunities waiver since it is a comprehensive waiver. But we are going to be looking at crisis therapeutic respite and enhanced behavioral support shared living option. I'll talk a little bit more about that in a later slide. In terms of recommendations for managed care engagement, as I mentioned, you will see the repetition of the education across agencies and making sure that managed care entities know what is and is not in the OCDD system, that we know what is and is not accessible in the managed care arena. We have a recommendation for a more formal partnership between the managed care entities and our OCD Resource Center clinicians so that we can be a resource to them and work together a little bit more early on when an individual might be having difficulty accessing services. The managed care entities agreed to do a survey of their clinical providers to see, well, who does feel like they have an ability and a willingness to provide treatment so that we know sort of where do we stand today. They know clinicians and agencies they can refer people to now, and we know where to target education to increase those numbers. Again, you have the repeat of the cross systems education for individuals and families so that they understand how to access services. There's a recommendation for doing some joint quality monitoring related specifically to meeting the needs of individuals with IDD and behavioral health, and are they able to access services, and sort of looking at are we getting access across the spectrum of service options. And then a consistent process for how do we engage for clinical consultation and planning across systems. So those were the MCO engagement related recommendations. The crisis system for adults was just rolled out. As we started this discussion, there is now beginnings of crisis services for children. So we may repeat some of this as well. There is a service, crisis stabilization and crisis intervention, that is available for youth. And one of the things that came out was similar to what I shared with our some of our services and our waiver options. There's not a lot of providers, so there's not access. So one of the things that was agreed is that the managed care entities and Medicaid and the Office of Behavioral Health would look at what's impacting the enrollment of these providers, and what do we need to do so that if we say we have these services, they really are available. There was a recommendation to work to clarify how the new 988 call centers and the managed care crisis call centers kind of work together, so that people understood those two options. There were also recommendations to the department to just assure that in any future changes in the behavioral health system, that the Office for Citizens with Developmental Disabilities and our stakeholders are involved in planning so that we can be sure that anything that needs to be considered so that individuals with disabilities can access those services, that we're getting that done early in the process. We made recommendations for required training for the existing crisis providers so that they could understand what behavioral health presentations might look like in individuals with disabilities, understand the services they should be able to access in the behavioral health system, and also understand the OCDD system so that if somebody needed to be connected to something related to their disability needs, that happened as well. We also had started some work and discussion with the Center for START Services, which is a national organization based out of the University of New Hampshire. It is the only evidence-informed treatment model for individuals with IDD and behavioral health that is specialized for that, right? So as Ashley mentioned, there is a lot of research about modifying existing behavioral health treatment, but this is a service that looks at individuals with pretty complex IDD and behavioral health needs, often ending up in crisis. And this is a treatment model that is very effective at reducing ER visits, hospital stays, et cetera, and improving positive outcomes for people to be able to receive services and live in their home and community. And we had begun discussion with them to do a systems analysis where they can look at even more formally than we already have, where are we spending our money in Louisiana and what's working and what's not, and how might we utilize the model that they have to enhance services and to sort of bridge the DD and the behavioral health system to work better together. So there was a recommendation to proceed with that, and then to look at, as I mentioned, funding crisis therapeutic respite in our OCDD system.
Hey, Brandy.
As it relates to, go ahead, Ash.
Hey, we have a couple of questions. I don't know if we want to try and answer a couple of them or just wait till the end.
Let's I'm thinking let's get through our slides just because I'm worried that
Okay.
All right. So as it relates to accessing psychiatric residential treatment facilities and or any specialty unit considerations that we might move forward with, the recommendations were sort of consistent. The first was we want to collaborate across all levels of care and make sure that the full continuum of services are available to people, and that when people have to go from one level of care to another, that there is collaboration and planning. We crosswalked the PRTF services with the old developmental neuropsychiatric program and looked at what would we need to modify, or what kind of things do we need to think about that might either help existing PRTFs better serve individuals with IDD, and if we were going to do a specialty unit at any point, what might that look like? We made recommendations to partner with existing PRTFs and treatment programs, and that refers to the grant that Ashley mentioned, kind of expanding what we were able to do to other PRTFs and programs. Exploring grant funding for startup for any specialty programs, and then partnering with the Department of Education so that we can make sure that youth and adolescents who might access some of these programs continue to receive the educational services they need while they're there. And then the other recommendations that the committee made was enhanced collaboration between the Department of Health, the Department of Education, the Department of Child and Family Services, and the Office of Juvenile Justice, so that all of the child serving agencies can work better together to help families assure that the needs of their loved ones are met. Communicating clear points of contact across systems for individuals and families so that people know where to go, right? Who do you contact and for what? Sorry, I got ahead of myself there. Making that sure that when we are looking at health equity considerations in any of our programs, that this would include looking at people with IDD and that their ability to access needed services, that we incentivize existing clinicians and providers because they may have to do some extra work and training initially. And then assuring access to needed inpatient services for those in ICFs, because we did discover that individuals who, especially adults in intermediate care facilities, are not in managed care because in general, for their day-to-day services, the intermediate care facility provides that via clinicians who are contracted. But what we know is that if somebody needs to go to the hospital, right, the intermediate care facility doesn't provide that. And so there was a barrier because legacy Medicaid can only pay for certain types of inpatient stays. So it limits their access, and that has become a challenge. And it means that if they end up at a psychiatric unit that is in a freestanding hospital, then it isn't covered, and the intermediate care facility would actually be on the hook for paying for that, which would be quite expensive. So we certainly want to be sure that when someone needs that, they are able to access it. So we're working with the ICFs now to make sure they know this, that the hospitals know this, and that they are getting access to inpatient care where it can be paid today, and that they, as a state, we are looking at what needs to maybe be different in the future. So those are the comprehensive recommendations from the group. Ashley and I are going to talk a little bit about which of these we've been able to move forward. before we sort of wrap up with you guys. So Ashley.
So the Arc of Louisiana has had a small grant through the Southwest ADA Center over in Texas. And in this last 5-year cycle, we made some changes to the healthcare disparities piece and wrote in some specific language that allowed us to really focus and expand our work on individuals with co-occurring disabilities, so individuals with IDD and co-occurring behavioral health conditions. So the first step to that was sort of putting a group, again, of stakeholders together across families and individuals to our key systems within the Department of Health, including CSOC. And we sort of just dove into sort of what were our main barriers. And one of the first items that came up was a lack of providers, community-based, if it's, a need of residential type treatment, the lack there. And the first thing we decided on doing was developing a guide for providers that could walk through some of those modifications and accommodations that they can make to their practice to make their services accessible to individuals with intellectual and developmental disabilities. What I've learned is the majority of individuals that have an intellectual or developmental disability have a mild developmental disability that the most simple and minor accommodations and modifications that can be made can make those services accessible. So we wanted to put out information to providers of the best practice of how to do that and some specific examples that they could use to then go and implement those and make the changes, to their practices. So that was the first thing that we really worked on. We got that provider guide completed. There is a link in this PowerPoint to that guide. Then we moved into the HCR. And then from the HCR group, our original group had wanted to complete an individual and family guide to help them walk through the systems to hopefully make accessing services so much easier, whether you're in a crisis or not. So we've been working over the last, I want to say about 7 months on that guide. And I'm super happy to say that as of yesterday, it is completed, and I will put a link to that guide in the chat for everybody to access. We are super hopeful that people find it as great as we think it is. And it's something that I wish I had 5-6 years ago when we really started trying to navigate across systems and just were met with barrier after barrier after barrier. So again, this was developed by families, by individuals with disabilities, these key players within the systems, clinicians, community-based clinicians, providers of these services, CSOC. It really was very much a group effort to get this done. So we're super excited and hope that you will find this guide as resourceful and helpful as we think it is. So we do anticipate this work group continuing to meet and work together as things arise, as changes are needed within both the provider guide and the individual and family guide. We will get together to make those changes and hope that we can, just continue the good work that we started a few years ago.
So kind of continuing as an extension of some of what Ashley shared related to the clinician guide, we obviously continue to do training and education through our OCD Resource Center clinicians. We're also doing some partnering with the National DD Directors Association and the National Association on Dual Diagnosis as well as some colleagues in other states, to really look at how do we keep education for clinicians going, and how do we do it more effectively. And so the guide Ashley mentioned is really specific to some things in Louisiana and some easy tips and modifications all in one place. We will continue to do training and put out other resources for clinicians as well. And so we are also changing the way we do that a little bit. So we're trying to make sure that we send the message that we're actually not asking clinicians to do something new. They do the work they already do, but they're just some basic modifications where that same work they do can benefit an individual with a disability, just like it would benefit someone who does not have a disability. And we have some white papers and tips for clinicians. They are on the Arc of Louisiana website on their healthcare page. They are also on the National DD Director's mental health resources page. And they take the common behavioral health treatment approaches one at a time and talk through in a few pages the research that shows that these modifications don't change the practice and they are effective, so that individuals with disabilities and behavioral health conditions can have positive outcomes. We also are engaging with some university partners and beginning to look at how do we expand our reach in terms of clinical treatment. So we are just starting a partnership with Ochsner Shreveport, where we are doing training with their psychiatric residents as well as their psychology interns. And we are going to utilize that experience to then do outreach to some other training programs so that we can begin to reach some clinicians in the time of their where they're getting training. And then we're looking at taking some of our trainings and actually doing short videos so that little nuggets of information, even when people don't have a lot of time or they don't want to feel overwhelmed by sort of an hour or a 2-hour educational workshop, that they can go and look at some of this information and feel a little bit more comfortable providing treatment. We are going to then work with Ashley and Kelly and others at the ARC to do some informational sessions for individuals and families so that they also can continue to get what they need to interface with clinicians more effectively. We've already started training with our partners in the coordinated system of care, and we are working collaboratively with all 6 managed care entities related to training for clinicians and providers in their network, as well as doing some training with their care coordinators related to our DD service system. So we've already begun all of those activities. We started some formal liaisons and partnerships. So I mentioned already the coordinated system of care. We're doing joint trainings with them. We also do some joint planning and discussions related to how we might meet an individual recipient's needs. We now have a formal liaison assigned and established with each managed care entity so that they can get to one of our lead clinicians quickly, and our lead clinicians know their lead clinician as well as their IDD liaison. They each have one so that we can work collaboratively together. We also have formal liaisons with the 2 state-operated psychiatric facilities so that when we do believe that someone needs inpatient treatment, beyond what you may get in a short-term hospital stay, we are able to work across our systems to make sure that people get that treatment, but that there's also appropriate planning when they are ready to discharge. And we already started training with the crisis providers. So we worked with the Center for Evidence-Based Practices at the LSU Human Services, Human Development Center, and we built a training for crisis providers. We've already delivered a training jointly with them to those providers, and we will continue that partnership as well. We are looking at the issues related to accessing therapies in the Children's Choice Waiver, as well as the complex care in the now. We've pulled all of the requests that have been made so we can look at what the outcome has been, what the problems might be. We've already begun drafting with the, we actually used the ARC group since that group was already together. We've already looked at some initial service definitions and provider requirements to begin building into our new opportunities waiver, enhanced behavioral support, shared living service, and a crisis respite service. The START systems analysis has started, and they actually just this morning sent out the email. I got it. Ashley's nodding her head, to begin a family survey. So they'll be doing family surveys, and they'll also be doing some focus groups. OBH has gotten some grant funding and has worked collaboratively with our office. They are drafting a request for proposals for a PRTF that would specialize in being able to meet the needs of individuals who also have IDD. So it wouldn't be that the PRTF service itself is different, but that there would be consideration of the additional needs related to someone's disability condition and making sure that they can access that. And we are also looking at opportunities to expand collaboration with existing providers. And then within our office, we are also trying to now move to a little bit more of a proactive approach where we really are looking at wellness. So not just treatment on the back end. And we're looking at positive psychology practices that we can actually infuse into our system. And what we know is that the research says when we can pair promoting well-being with treatment using traditional behavioral health practices, that's when real change happens and it is more sustained. So we have now taken some of the partnerships that I mentioned early on that we had between the local district and authority and our resource centers, and we are formalizing them into some waiver practices so that we are catching situations where someone might be having the early risk indicators, right? Repeat incidents of certain types, where we are then utilizing the partnership between our resource center and the local staff to see what is missing in the support structure for that person so that the person doesn't have to continue to have those types of incidents. So it will include the urgent triage and diversion that I mentioned, as well as the local oversight team, but we are expanding it to some other risk situations. We also have developed a DSP wellness training that we are about to roll out so that we are shifting the focus of supports to promoting wellness. And moving a little bit away from the more traditional positive behavior support or PBS focus, not because it is not something that is good, but we really actually want to do something sooner than that. We want to make sure that folks understand we need to support wellness, even if someone isn't having behavioral health issues or behavioral challenges, because that's how we often prevent those. And we just finished an individual and family wellness toolkit, which Ashley does not know yet, but I'm about to send to her, that we also want to look at how do we get those tools out to individuals and families so you don't have to wait until you're getting a service or having a provider. Anyone that is, can use it. You can use it at school. You can use it with family members who may be providing support, et cetera, so that we promote wellness at baseline.
And Dr. Kelly, I'm going to go ahead and jump in. I'm sorry, we're almost out of time, but we do have 2 additional questions I want to make sure get answered very quickly. Sandra asks, saying the great resources with CHWs, would that be offered through the members' waiver, through their waiver case workers, or through their MCO?
So the community health worker would be accessed the same way it would for anybody who did not have a disability. So it wouldn't be different. What we have not had yet, Sandra, is any in-depth conversations in the department so that, how a care manager on our side kind of connects somebody in. Yeah, I don't know all those nuts and bolts, but the access point would not be any different.
And lastly, Pamela asks if who is the contact person for Ochsner LSU HSC initiative in Shreveport on the OLSU side?
I would have to get that name. So Dr. Bounds, who is our associate clinical director, is actually our contact.
Okay.
And he's working with them. So I can certainly try to get that information to Dr. McPherson if she wants that. But I don't have that name readily available to share.
Well, that's fine. We'll make sure that we'll follow up and get that information out. So I want to thank you both again for being here, and thank you for your time. This has been a really great session. Our next session will begin at 10:30, and you are welcome